Yeah, I think what we really asked for this subgroup analysis is really to understand, what is driving progression and whether, the benefit that we see with lenvatinib and pembrolizumab can be maintained in this specific analysis. And we use different categories to group patients into lung, lymph node, liver, bone, CNS metastasis. And we look for events that drive progression here. So we counted only progression within those organ metastatic sites, really for progression. And I think, there is, the numbers of CNS metastasis, for instance, is low, and it also influences, of course, the event rate. But overall, I think what we have seen is very stable and benefit that is maintained with the combination of lenvatinib and pembrolizumab over sunitinib. Well, I think what we were interested in is really what is driving post-protocol survival, actually, and what could be a discriminator. And we looked therefore into the tumor burden at the time of progression. And what we have seen is really that when you use the combination of lenvatinib and pembrolizumab, patient had at the time of progression about a 48% decrease compared to the baseline tumor burden, and it was superior to or higher compared to sunitinib, which was only 17%. And I think, this observation it could be important in a way that patients are in a better disease state when they went, into progression and then into second-line treatment. And I think that's something we need to explore in more depth in order to understand the meaning of this observation. Yeah, I think, what we looked into is really how many patients had subsequent lines of therapies, and we then looked into the two most frequently prescribed TKIs, which has been cabozantinib and axitinib, and we wanted to understand, how that really paid out in the end after previous treatment with lenvatinib and pembrolizumab, and then also with sunitinib. And what we have seen is higher numbers of the median time to discontinuation of this type of therapy when it comes to the sequence of len-pem followed by one of those TKIs than compared to sunitinib. And we do believe that, probably the amount of tumor shrinkage that I referred to previously could play a role in this sense. And I think, something you have to be cautious about is really that it has not been pre-specified, that you have to use a certain TKI. So there is a certain bias introduced when it comes to numbers, and those numbers should not be really compared and in a way that axitinib or performs better than cabozantinib. I think that's the caveat that we have to face here. I think is an additional piece of really data that supports the use of len-pem, and shows how robust the data is. And we were keen on doing this exercise in order to understand, what is driving progression here. And maybe, there's a subgroup of patients there's either tremendous benefit or even less benefit. But as it appears, it's quite even overall. And I think it's this analysis supports the use of len-pem as a first-line option in kidney cancer patients. And that's basically the main message that we have right now.